slides. Hopefully my screen will my share. Oops. There's a little sneak preview of JoJo. I mean of Smidge. Awesome. Is it showing the? There we go. Is it showing the big screen?
Yep.
Yes,
it is.
Awesome.
Yep.
Cool. Great, thank you. So today we're gonna have some great conversations today about liquid oxygen and COPD basics. So here's our agenda. We're gonna run through it. First, I want to share that, throughout the year, we often get really good opportunities where members of our patient advisory groups can be showcased, their story can be showcased in different newsletters, online publications. And so this is as recently as about 2 weeks ago, healthline.com reached out to us and said that they wanted to do a feature story on a COPD patient. And we gave them Midge's name. And so I'll share this with the group. And she talked about from being a bodybuilder to a COPD patient advocate. So as Bev said, if we haven't talked to you yet, you will be hearing from me because we get many offers throughout the year. So excited and want to thank Midge for participating in this great article. And I will send the link to folks, but it's a great story. Good. The other exciting thing that I want to talk about, we talked about this during our kickoff call, and we talked about it from last year as well. We reached out to, in January, I reached out to all of the ACRC PIs and asked them, would you be interested in having our patient advisory group's voice as part of any of your current research efforts? And we have 6 universities or hospital systems that have expressed an interest. So at the bottom of the screen, you can see it's Rush University, Baylor, National Jewish Health, Temple University, Ascension St. Vincent, and UCLA. So more to come on that. The questions that we ask is what type of interaction would you want? And some of them said one-on-one telephone interviews. Some were online surveys. A big chunk were focus groups. And so more to come. How we will structure that is when I have the information, I will send it to the group. And of course, all of this is optional for you. If you want to participate, obviously we welcome you to, but it's not mandatory to do all of the programs that are offered to you. But we're super excited because this is the first year that we've reached out, and I think we were very excited with the 6 universities or the 6 systems that we have. So more to come on that. So don't have the definite date yet, but I promised you this as well, that we hope in September of 2022 that we will be in person again. Of course, only if, it's in the best interest of everyone's health and safety to travel again, but we potentially will be having an in-person meeting in Baltimore, Maryland, and it's the exciting opportunity that we get to have the researchers and the patient advisory groups together. When we have a definite date and we have the possibility, I will send all of you the information. And again, this is not a mandatory, it's not mandatory for you to attend in person. It can be done virtually, and we will only be in person if things are where they should be when it comes to health and safety. But more to come. But we're very excited that there's a possibility in the very near future to get together in person. Then the last activity that I'm going to do for April, we have some of our patient advisory groups members' bios and photos on our website, but we don't have all of them. And I'm going to be reaching out to you in April and to get you to update your bio and your photo. Many of you, when you joined for our newer members, you did provide a bio to me, and we just want to kind of put it in a format, and then we're going to put everybody's. If you are willing to do so, we're going to put your story and your bio on under our ACRC patient advisory group members. So expect to get that updates from me in the next 2 weeks, 2 to 3 weeks. Now, Miss Jill and Miss Bev want to talk to you about a new COPD basics program that many of you have already given her a lot of great feedback for, but turn it over to you, ladies.
Great, thanks. I think I'll tee it up and then would welcome Bev to jump in as well. We are thrilled that through an endowment, we have the funding to build out an online interactive educational module that we're calling COPD Basics. We can call it something more fancy, but right now we're going to just call it COPD Basics. And the goal of this is to provide initial basic information to individuals with a new diagnosis of COPD and their caregivers. So we have been pilot testing and interviewing our key audience about what should be covered in the COPD basics. How much is too much information? How much is too much detail? What's the right length? But we'd like to hear from you as well. And so this is an ever evolving, constantly evolving outline and narrative, if you will. And so we have passed something to all of you to review, but one of the things that we've come back with is, just to prime it, is we have made the decision to divide it into two sections, and we'd like you to tell us if this is a good idea. And so we've decided to divide it into two, instead of an hour-long interactive module, into like a 30-minute and then a 30-minute module. So it's a little less overwhelming. So my first question for you is, does two modules and a 30-minute interaction and then come back in a 30-minute interaction, does that amount of time seem appropriate if you were just getting your diagnosis and that's the amount of information you would be comfortable engaging with and not being overwhelmed with?
I think so, because it's overwhelming to get a diagnosis of COPD, and we're learning forever all about everything relevant to COPD. So I think that sounds better. 2 30-minute modules. Yeah.
Yeah, I would agree. I guess one of the things that did strike me when I was looking at the information that you sent out ahead of time was that it did seem like there was an awful lot of information, probably way more than most people would be able to absorb. The other thing that I would suggest that you might think about is the possibility of, within the module, providing the basics, but then adding a link to more information, to learn more, click here kind of thing, so that you can include a lot of the detail that you're probably not going to be able to get to in that first half hour or whatever, but allow people to go back to this, to pick it up and say, well, gee, I really need to learn a little bit more about oxygen, or I need to learn a little bit more about the kinds of inhalers that are being provided, that sort of thing.
Thank you, Jean. And yes, since the draft we sent to you guys, we did divide it into two, because we had, like I mentioned, we'd been pilot testing, and we found that, there's a point you know too much, right? And we were like, oh, let's tell them everything. And then we were like, wow, we had to pull back. And so I thank you for confirming that. And also I liked your idea about link here if you're ready for more information. Thanks.
I would like to say that I think the links to more information would be a very good thing. Also, even broken down into 2 30-minute sessions, it's quite a lot, I think, for you to take in when you're first diagnosed. I mean, it's such an overwhelming diagnosis that I'm not sure we could take in 30 minutes at first.
Okay. Well, yeah, that raises another question, I guess. Are you planning on this being something that is presented over a period of 30 minutes that's dictated by like the flow of the slides or something on that order, so that the person can't kind of stop and say, I got to think about that?
You know, thanks, Jean. That's a great question. We envision this to be delivered in a few ways. We are building it to be an interactive online self-paced module.
Okay.
So somebody can go through it like asynchronously online, and then they can do a repeat of like the last little section if they want to, or if they're ready, they can click next. We recognize my father has severe COPD, so I'm kind of also thinking about my parents as a user who neither one of them have any computer skills. And so I'm also we're thinking about that as well. And so we need to make sure that we can meet the needs of a broad audience and some people that are computer savvy and some that are my father that doesn't know where the on button is. And so thinking about having limited buttons, and so that's something we're considering, but it would be something where it is somewhat self-paced.
Okay.
So people could repeat a section and listen again.
Okay.
Or they can, when they're ready, they can hit next. Or they can stop at any time as well and go, okay, I need to come back tomorrow or later today.
Yeah. Okay.
I think you mentioned, so to speak, that going from the first 30-minute module to the second, you can do a little review of the first at the beginning, right? I think you said something to that effect, because I think that would be good. Yes. I'm a former educator, so you're reviewing prior knowledge before you're leading into the new knowledge. Yep. And what about, can there be a follow-up after the 30 minutes in the future? Just, I don't know if you need funding for that or somehow just a follow. It doesn't have to be 30 minutes, some kind of follow-up.
Tell me what you mean, please, Carol.
After 30-minute, I don't know over what period of time, a third module, brief, just to go over, let's review what we did in the past or something like that.
I like that idea.
To reinforce what was previously done.
It's almost a scaffolding of education.
Right.
And that's what we were thinking of doing in parts 1 and 2, is introduce the concept, let's say for medications in part 1, but then in part 2, we would do a brief review and then a deeper dive.
Right.
But hadn't thought of a part 3. Thanks for that comment.
So Carol, when you were talking about that, I envisioned something a little bit different, and this, tell me if this is a bad idea. It almost could be an email follow-up with a video. Like you could read it or you could watch it, but it's hope you're doing okay, hope things are going well, this is still available to you. If you have questions, this is who you can call, this is where you can go. Or were you thinking really like a third review of the content versus a check-in?
Maybe a combination.
Okay.
Maybe a combination.
And how
I didn't
long
really
would
think deeply about it, but in other words, you just don't finish. It's never, as I said, it's never ending for us, our education with the disease. So you're starting with people who are new to it. You have 2 30-minute sessions, then a third, I don't know what period of time afterwards, but maybe a combination to review or how are you doing or that kind of thing.
That's great. Okay.
That leads into all sorts of great possibilities of ways to monthly or quarterly of those individuals that have completed it. We could reach out to them almost through the Better Breathers Network, and here's new resources, or here's a new medication, or complementary therapy. So there's a lot of opportunities there. Okay. So we've talked a little bit about the length and also about this is overwhelming in the beginning, so keep it simple. So I would love to also hear back from you about the tone of this. And we've kind of gotten a little bit of mixed messages about the tone. We've heard that the tone should be very hopeful. We've also heard that the tone should be, this is serious, take it serious, but there are medications and therapies to help you manage this disease and live a full life. So can you provide us some feedback of what tone we should go in with?
Well, since I was in denial for quite a while, I believe that this is serious, but there are, well, by the time I figured out it was serious, then I needed that encouragement that even though it's very serious and there's no cure, there are things that we can do. That was sort of my progression.
Great, thank you.
Yeah, I agree with Carolyn. Like her, I was definitely in denial and really let things go to hell in a handbasket for a couple of years. And actually, at the point at which I really decided I needed to take control, the person who really pushed me to doing that was my primary care physician. And at that point, it was about 2003. I don't think that I had done much looking on the internet, or if I hadn't paid much attention to what I found. And what I found at that point was pretty limited as well. And so now it's different because a lot of times we're now in a group, the people who are being diagnosed very often now go to the internet first thing. And what they find there is really important. Yes. And so I do think that Carolyn's right. You need to say that this is serious. It's not something you can ignore. But I do think that key is you can't ignore it, but there are things you personally can do that will really make a difference in your life and how you live your life and what kind of a life it is.
To pick up on what Jean said just a little bit, I think that one of the important messages that COPD patients need to have is that you are the one who can do the most about this. More than your doctor, more than the medicine, you have to take control.
Absolutely, Carolyn. I think you're absolutely right. And I think one of the messages that I think is beginning to become much more obvious is that what you do as an individual and the lifestyle changes that you make will make the biggest differences in what goes forward from here.
And actually, that gave me a lot of hope. The fact that I could control a lot of what was happening to me.
Yeah, I won't ever forget my first visit to a pulmonologist was in 2005. And that was after I had gone through this really aggressive diet and exercise program and had really made tremendous progress. But I remember sitting in his office and he says, well, here are the things that you need to do. And he wrote them out on a whiteboard. And then he looked at me and he beamed and he said, and you've done all of them. And that was the most empowering thing that anybody could say to me. So somehow or other, we need to be able to give that kind of affirmation to people. You know, the fact that it's there, that it's possible, that you can do it. And then we need people like Carolyn who can tell us that, yeah, and in spite of all the adversities, you can do it.
Thank you. Thank you. My next question is, to what degree should we cover smoking cessation in part 1 versus part 2?
Part 1, smoking cessation should be one of the first steps to move forward. So I think it should be stressed as soon as possible. I mean, to be honest with you, I was a smoker and I stopped smoking in 1991. And then when I was getting shortness of breath in 2014, or actually several years before that, I didn't even connect it, you know, that it was respiratory. I was going to the cardiologist and I was the stereotype who was undiagnosed for several years until finally I knew it's not my heart, you know. So I had stopped smoking. And Jean's story is otherwise. You didn't stop smoking right away because you were in denial. You know, everyone has a story, but that's one of the most important things is to stop smoking right away, which is hard for some people.
It's very difficult for some people. I think I agree wholeheartedly with Carol. We definitely need to address it. And maybe it needs to be addressed, you know, in a couple different places in several different ways. Oh, shucks, I've got to take this call. Sorry.
Sounds like bagpipes.
It's a good,
Mhm.
good tone.
And I think the reason for my question is we want to ensure that we engage the individual moving forward. And if this is a sensitive subject, we don't want to, and they're in denial, we don't want to shut them down.
Right.
That they won't go forward. Secondly, we also know that smoking is not the only reason people get COPD. And so my father's was not a smoker. And so he received it from an occupational exposure. So we don't want to turn off those people that develop COPD from something else. And so we're trying to figure out that balance. And I don't think we have it yet.
Can I say something? I'm gonna wear a provider stakeholder hat here about
Please.
this. So I think if you focused in the message of the important or how harmful it is to continue smoking in an already diseased lungs, I think that's, you know, because there's a specific problem for the COPD people to continue to do so, right? Regardless of how it happened. So my sort of a perspective is that you guys have a very good program for smoking cessation, right? But that's for everybody, right? It could be for 20-year-old or it could be for COPD patients. You have some general great training or resources out there. But I think for this purposes, you can consider focusing on the COPD people. If they keep smoking, what will be the decremental effect on that too? And then we have some data out there too, you know, about the lung function decline. And, you know, you guys probably seen that, you know, the picture of how quickly the lung function declines if you have COPD and if you smoking. And, you know, we have, good visual data to show that as well. And then that's something that I use for my patients when we talk about it. Now, of course, I can't say that I can convince everybody, but so visual effect on what happens, because I think that might be some information that they have not seen before, meaning they have probably heard millions, 10 million times to stop smoking, but whether that information about how detrimental it is for the already diseased lung, that will be probably the focus message that may be actually more appealing.
I think, Jill, I think it would be important to, mention it, but also, do talk about that we have a separate program, and it be something separate, like a link to,
Right.
smoking cessation and, secondhand smoke, like those things should be separate links.
Right. And then that's just something somebody, was it Jean or was it Caroline? Somebody mentioned about the links, right? So I think that's kind of like where the link comes in handy, probably.
And then also avoiding secondhand smoke.
Yeah.
That's another good important.
I think you need to approach it a little bit cautiously. That I think what we've discussed would be good. But at first, I would have just shut you down if you said you got to quit smoking. I just wasn't ready to hear that until I ended up in the hospital. Then I was ready to hear it.
So, Carolyn, you were not ready to hear it until you were in the hospital, ready to go back, until you had to go to the hospital.
No, I wasn't ready to hear it yet.
Well, yeah, I think part of what you have to do is you have to think about the motivation of the smoker.
Mm-hmm.
Because like Carolyn, I wasn't ready to quit until I quit. And I was unlike a lot of people in that I had not even really tried to quit. Even though I'd gone through some of the motions occasionally, I knew in the back of my brain I was not going to quit. And so, and what happened to me was I suddenly realized one day that I was scheduling my entire day around when I could have a cigarette. And those damn things were essentially running my life.
Mm-hmm.
And I'm type A enough that was just absolutely, I can't deal with this. Those things cannot do this to me. So I quit. But I did not, believe me, I didn't quit until I quit. And so somehow or other, people have to have that motivation. And, I don't know whether showing them what's happening to their lungs will make a difference. I don't know. You kind of have to try a lot of different things, I guess. But people have to reach their own point.
Mm-hmm.
And we probably just need to recognize that.
Mm-hmm.
And maybe give them some of the obvious things to think about. I think showing them pictures of what happens to the lungs may be something that's really helpful. I'm thinking maybe to talk about children and grandchildren and milestones that are coming that you want to be a part of. For me, the motivation actually was my doctor had said, if you lose some weight, your problems aren't going to go away, but they're going to get better. And I didn't think he thought I could or would. So that made me angry. The other thing was that I had landed in the hospital and I was getting 6 liters of oxygen out of a wall. And I was still a little short of breath just sitting in bed. That was pretty scary. But then the thing that probably was most important to me was that I knew that my husband was beginning to show the first signs of Alzheimer's. And if I wasn't around, he was not going to be able to function well on his own. And the other piece was that I think I finally had realized that this really was serious. It was way more serious than I thought it was.
Mm-hmm. Mm-hmm.
So I'm hearing a couple messages here is that it's vitally important that we address smoking or whatever is the exposure that caused the COPD. And the point of when we have smoking or the exposure, it's very harmful to the already diseased lung, but we need to be very careful that we don't shut them down and then they're like, forget you, I'm done with this. So we need to introduce it gently in the first part 1. Introduce it. When you're ready, we're here to help and and get them to one of our exceptional smoking cessation programs. And then come back to it again in part 2, and we can come back to it again. So very gentle, respectful, cautious in part 1, and then we can bring it up again. And we don't want to shut them down in part 1, but it needs to be addressed. Okay. And then also, Jean, I heard what you're saying about, what are the motivations for not only smoking cessation, but the entire self-care of this.
Yeah.
Super. Okay.
Right.
Real quick, and then I'll pass it back to Annette, and maybe Bev has some questions. Anything else that you think of that you would really want us to make sure we include in the information when you were first diagnosed?
Exercise is a mandate, really. It's critical. Exercise and diet, proper diet.
Okay.
Carol, I think you brought it up last time, or maybe it was Jean, about how marketing to COPD patients that going to the gym, you can go to the gym and you should go to the gym. That was a really good a note that I think would be a good campaign too, is that, I have COPD and I can and enjoy going to exercise.
Jean, I remember years ago you told me your treadmill became your best friend.
Well, yeah,
Ew.
Unfortunately, I sold that treadmill
Oh
about 12 years ago. But I moved to a place where I have 3 that I can choose from.
Good, good,
Well,
good.
we've known each other a long time, Jean.
Great.
We're planning on framing it in part 1 as not exercise, but staying physically active, because we don't want people to shut down and go, I'm not going to the YMCA.
That's good.
And so starting with the staying active and then building on what does that mean?
I think that's very, I'm
Go
sorry,
ahead, Carolyn.
I think that's a very good idea because I don't think there's enough emphasis in most cases put on the fact that doing your laundry, doing housework, doing daily living type of things are very important as far as being active. They're important also. You need an exercise regimen, but you also need to, as much as you can, I think as long as you can do it, you need to do it. You need to do as much as you can.
I agree, Carolyn. I think it's important, though, to make the distinction that
Yes.
just because you do those things, that you still need that formal exercise program, because part of what you're trying to do is you're trying to build endurance, strength, and stamina. And if you can load the washing machine, that's fine, but that involves going to the laundry basket, getting the laundry basket to the washing machine, loading the machine, sticking the detergent in, turning it on, and then going to sit down.
I agree.
And that's not exercise.
Right, I agree. But on the other hand, some people, I know a person, for instance, who does their exercise 40 minutes a day and sits on the couch and watches TV the rest of the day. Well, that's not good either.
No. And I guess one of the ways that I've seen it framed by a number of people is, and my good friend Maggie Borger, who is no longer with us, was the person who said, I do my exercise so that I can have a life.
Right.
She was the first person who said that to me. And her life was primarily her grandchildren, and trying to keep up with them.
Great. Thank you all so much.
Can I just make one before we close? I think this is a really wonderful idea. I'm just gonna wear the provider hat again and just ask here. So it's great to have the web-based thing, but it's in the, if we were to try to promote it when we use it in our clinics, it's nice to have something that we can hand out, because I can't scrabble the like ALA.org, blah, 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 blah in there too. So if there's something that we can give that has the link on it, that kind of correlates with, COPD basic, blah, 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 the link is that, and then we can hand it on, because I think patients likes to have some paper to take home with, because if we were to verbally say something or scribble something, it's gonna get lost, right, guys, right? Right, so something to have it there, that we can, just hand it on. I'm thinking about ahead, about the dissemination portion of it too, because that's really nice to have too. And sometimes I ended up writing in this stupid piece of paper and somewhere, and then I know it's gonna get lost. So there's something that, it's nice that we can hand out. That would be nice. Not the content, but just the introduction that has a link on it. Yeah.
Okay, great. Bev, did you have any questions, or I'm gonna turn it over to Erica?
Why don't you go ahead and turn it over to Erica, and if we have a couple more minutes at the end, then we'll use them up.
Okay, great. Well, everyone, I want to introduce you to Erica Sward. She is going to talk to you about liquid oxygen.
Hi, everyone, and it's good to see one of my partners in crime, Jean, on this call. I am Erica Sward. I work on our policy and advocacy team at the Lung Association, and I have a 13-year-old almost. He'll be 13 in July. And the reason that I share that is that right before he was born, we spent months working on the issue of legislation to reform the supplemental oxygen system and payment system under Medicare. And it is just as messed up now, if not more, than it was then. And I am seeing some nods. So what we are trying to do, and as Jean knows and has been our biggest networker and advocate, is that we are working with a whole host of different organizations, from the American Thoracic Society to the American Association of Respiratory Care, to the Pulmonary Fibrosis Foundation, and others, to try to identify people who had liquid oxygen or have liquid oxygen and are enrolled in traditional Medicare. So we've hit two buckets so far, right? Traditional Medicare, liquid oxygen, and have been told by their supplier that they are no longer able to provide liquid. And what we are trying to do is to gather, and we have a couple. Jean, I'm sorry I missed the meeting on Monday, but we have a couple. And we are essentially needing to have those tangible examples to go back to the Centers for Medicare and Medicaid Services to say, look, we have these examples. We need you to look at them and go from there. So if you or anyone you know has been impacted by this, and that's from a patient, a friend, a provider perspective, please reach out to Rohan or me. Rohan, I don't know if you introduced yourself at the beginning of the call, but we are really trying to collect all of these so that we can show and demonstrate to CMS that we have a major challenge and that it needs their attention. So I'm going to pause there, see if Jean has anything she wants to add, and kind of go from there.
Just a couple of things. The first one is that if we do know people who have had liquid oxygen and have lost it, it needs to probably be somebody to whom this occurred within the last 2 or 3 years. Yeah. If you get much beyond that, then it's lost its flavor, if you will. The other thing is that we're hoping that we can get people to ask for liquid oxygen. And this gets to be kind of interesting because there are so many places in the country where liquid oxygen isn't even available at all. And so nobody even asks for it anymore. I'm one of the few people who still uses liquid oxygen, and even before the pandemic, when I was traveling, I probably hadn't asked for liquid when I was traveling for probably 10 years because I hadn't been able to get it. I hadn't even bothered to ask for it I wish I had now, because I could have demonstrated all those times that I've been turned down. But it's demonstrating that you've been turned down. It's incomprehensible to me, frankly, that CMS does not understand that this is a problem. They have all the data somewhere in their system that shows exactly when people were denied liquid oxygen, and they can't find it. So as far as they're concerned, they don't have a problem. And we're the ones who are trying to demonstrate to them that there are enough of these cases that they need to start looking at this. So it's going to be really interesting to see how this plays out. So if you do know people, please encourage them to do this. If they'd ask their doctors for liquid oxygen and then get the denial, that's fine. We can turn the denial in, and that's a demonstration. The other piece is that it really involves a tremendous amount of paperwork. You've got to be able to demonstrate, because if it isn't on paper, as far as CMS is concerned, it didn't occur.
Yep. I really want to underscore that, and we've had a whole kind of protocol figured out and everything else, particularly within a working group that Jean and I are both on, and we need to document all of it. And some of it is finding a patient who is currently stable and uses oxygen to see if their provider is willing to write them a script for liquid if it is medically appropriate. And then getting that code back or getting the paperwork back saying that it's been denied. And that is exactly what we need. And so sometimes the supplier will call the provider and say, oh, we don't have that. What's your second choice? Can you fax over that second choice? And it's like, no, you need to write that down, because we need to get you. And so that's where we're at there. So there are a lot of reasons for all of this. It's very complicated from a payment perspective, but we're unfortunately not anticipating that CMS's tune is going to change, but we need to go through this so that we can get some reform on Capitol Hill. So that's where we're at, and greatly appreciate any additional thoughts you have on this space. And we appreciate any providers that you may know who'd be willing to take a spin with us on trying to get a few more refusals. And also, if you know anyone else who's been affected by this, please send them to Rohan and to me.
Great. Awesome.
Thanks so much, Erica, for your time.
Thanks, Erica. Thanks, Rohan. Next, we're going to turn it over to Elise Wallace, and she's going to give us some exciting news on some new reports that are out.
Yes, hi everyone. I wanted to briefly talk about two reports. The first one is our new zero emissions report, and I'm just going to pull up a couple notes that I have here. And this report came out this past Wednesday, and we're really excited about it. It builds on a report that came out a couple years ago called The Road to Clean Air. And basically this report oversees the health and climate benefits of a nationwide transition to zero emission vehicles and electricity. And so when we talk about zero emission, this transition, we not only refer to passenger vehicles, but we're also talking about heavy duty trucks, school buses, commercial hovercraft. So really making sure that all of these types of vehicles move to zero emission technology. And I also wanted to mention that the transportation sector is one of the leading sources of air pollution. It's also the largest source of greenhouse gas emissions that is driving climate change. So this transition is so important when it comes to protecting lung health and advancing health equity. So right when I'm done presenting, I will put that link to the chat, link in the chat to the report so you can take a look at it. And I also wanted to mention that we do have a petition that goes along with the report. And this is really urging our federal government to make sure that this zero emission transition happens and protects our communities. And then the next report that I wanted to briefly talk about is our 23rd State of the Air report. So this report is going to be released later this month on Thursday, April 21st. And this is our signature report that looks at the nation's air quality. And basically what it does is that it ranks cities and counties across the US when it comes to their air pollution level. So really encourage you to take a few minutes to check that out once it becomes available and kind of see how your county and state measures up when it comes to air pollution.
Great. Thanks, Elise.
Thank you.
Does anybody have any questions for Elise? Okay. I'm going to now go to Elise Klinger to talk about, each time we talk to you about the Better Breathers Network and the transition to the work that we're doing.
Thanks, Annette. Hi, everyone. So I believe on the last call, I also mentioned it, but just a quick reminder to join the free Better Breathers Network. As you see on the screen, we have a nice little roadmap graphic for you. Once you join, make sure you check out the Resource Center. Also can be found on london.org/BBN Resource Center. And then you can just follow the trail and make sure you get involved with all that the Lung Association offers. But if you haven't already, please join. We also have a Living with COPD online support group on our Inspire platform. So that's just a way for you to virtually connect and support each other with others living in your shoes.
Great.
Thanks.
Thanks, Elise. And this slide is always here because we're always asking this, and I believe I have most of the folks on the call. I do have your story, but one of the things that we really have a targeted approach is that we want you to help us articulate the need to members of Congress and making sure that everyone has access to quality and affordable health care. So if you have not shared your healthcare story with me, please do so. And you can I can set up an interview with you, or there's a link that's all of this information will be provided to you in a follow-up email. But there's the opportunity that we really want to help let our members of Congress know the importance of this quality and affordable health care. We do have next Wednesday for our lung cancer patients, we do have a Lung Force Advocacy Day, and that is one of the asks that we have with our lung cancer patients, but it is a universal ask across all lung disease patients. So, and now I just want to open it up if there's anything that anyone else wants to talk about today. If not, look for a big chunky email from me in the near future of lots of exciting opportunities.
I'm going to jump in really quickly with, there's a couple things that I'm working on around severe lung infections relating to people with COPD. I've talked before about looking for somebody who had pneumococcal pneumonia, and to my recollection, that wasn't anybody in this group. But we're also starting to look at pertussis, which is more commonly called whooping cough. So if anybody has a personal story relating to pertussis, I would love to talk to you one-on-one about your experience with that. We're also creating an animation and some new information about recovering from a serious lung infection, regardless of what it is. Really like pneumonia, COVID, pertussis, all of these different things. So if you have experience with recovery, and really I'm talking about recovery that takes longer than you think it should, and helping people get back to where they want to be, I'd love to talk to you about that too and make sure that the resources that we're creating are on target. So I'm going to pause there really quickly to see if any of that resonates with any of you.
The recovery piece.
Okay, Jean, that's great. Thank you. I'll make a note of that. I also made a note, and I haven't gotten back to you yet, to talk to you about bronchiectasis. It's on my list. It just hasn't made it to the very top. So we'll have a great conversation about that as soon as I get all my ducks in the same pond. The other thing that I'm working on right now, and I'm hoping that we can talk about it in a future meeting, is there's a lot of conversations, and the Lung Association has been invited to participate in them, and what patients are looking for next as far as treatment, as far as symptom relief. And I want to make sure that the language that I'm talking about reflects the good thoughts that y'all have. So I don't have anything yet because I don't have the questions that are going to be discussed. For example, I'm going to be part of a international group on April 29th, but I don't have the agenda yet. So I'm hoping to shoot that out with a little bit of notice and get some feedback from anybody who's available, just to make sure that I'm representing your thoughts and opinions well. Those are my 2 updates.
Okay, great. Anyone else have any other thoughts or questions they'd like to ask? Okay. Well, thank you all so much for your time today and your continued support and efforts with the ACRC Patient Advisory Group. If you didn't notice, we did this month, this court did separate the COPD patients and the asthma patients, not because anybody's misbehaving, but because we wanted to have separate conversations. So we will continue to have alternating meetings together in single, but we're meeting with the asthma patients next week. So great. Thank you, everyone, and take care.
Thank you.
Thank you.
Bye.
Thank you so
Bye-bye.
much.
Thank you. Bye.